Hello, everybody, and welcome. And first of all, apologise for my voice, which seems to have disappeared today. But the good news is that the lovely Julie Van Olsen has a really great slide pack to show us, so I don't need to talk. We don't have to all suffer my voice. But anyway, some of you will have met Julie in various guises. You've done one of our coffee mornings, Julie, haven't you? And
Yes,
you are absolutely a stalwart on our online clinics for dermatology. Now, Julie, it's probably better for you to explain who you are, but Julie is I was going to say nurse of many years, and that sounds quite rude, but what I'm trying to say is a nurse with vast experience in dermatology. So if you'd like to just tell us a little bit about you, Julie, that'd be perfect.
Yes, well, hello everyone, and thank you for joining. So my name's Julie Van Onselen, and even though it makes me feel a little bit ancient, I have worked in dermatology. I've been a nurse for just 40 years this year, and I've worked in dermatology for 32 years. I have worked the whole way through. I only had 1 year break for maternity leave, so perhaps 39 years is fairer to say. I've been in dermatology for, as I say, for 32 years, and I'm very, my sort of passion really is trying to help people with skin conditions lives be better, and also to help educate healthcare professionals to look after patients or people with skin conditions better. So I have probably what I've called a portfolio career now. So I have obviously worked in dermatology departments. I've worked more probably in primary care than secondary care. But if I come right to the present, my week consists of working for a charity called the National Eczema Society on their helpline and helping them with information, working in a skin cancer assessment clinic, which kind of qualifies me for this talk today, which actually is a private service, and also doing a couple of days teaching and training a week. And I also have an NHS position twice a week as well. So I'm quite busy. I'm probably about 50-50 working as a clinical nurse and working also as a teacher. And of course, alongside that, the charity work. So that's me.
I think it's really important, as what we always say to people, with doctors have so little training, don't they, and little time when they're at medical school on dermatology issues. So whenever you do have a dermatology issue, it's always worth asking if your practice has a GP that specialises in dermatology, because that is a much better step to go down than a standard GP, isn't it, Julie?
Oh yes, I think it is useful, and a lot of GPs, they have to be masters of everything, but actually a lot do develop special interests, not just in skin and other things like ENT or possibly ophthalmics or something like that. So, but I think there's a growing number of GPs taking more and more of an interest. And in fact, one of my other roles is I am on the committee of the Primary Care Dermatology Society, and I'm going to actually show you some web pages which are open to the public as well. And we exist purely for education of primary care professionals, but because it's so important, the website is open to the public at large as well. So that's really useful, because you can actually then see on this website what treatment pathways perhaps should be. And as I say, often the GPs are trying their absolute utmost and best to care for patients with skin patients, but unfortunately dermatology is still not compulsory in general medical training, in nurse training, and even in postgraduate training such as GP training. But 25% of people who walk through the door in primary care have a skin condition. So there we go.
Frightening, isn't it?
Yes.
So what a lot of you very kindly sent in some questions, which I actually gave to Julie before. So she's put many of those answers to the questions that you've had into the webinar. If there's anything that while we go along, that you fancy, just please put as normal questions into the box, and we'll gather those up towards the end of the webinar, and hopefully Julie can answer some of those for you. Julie's got the slideshow. So Julie, should we put the slideshow up? And if I just, probably best thing is if I just let you carry chatting through it rather than me trying to go in it.
Okay, no, that's fine. Can everybody can see that, I assume?
Yeah, that's perfect. Thank you.
Okay. So thank you, Katrina, again. So I think I'm just going to talk through the presentation. I'm very happy for Katrina to interject, or if any interesting questions are typed into the question box, or are they going to be typed just into the chat function rather than question and answer?
No, we put them into the Q&A, please.
The Q&A, yes, yes. So just to confirm, there's if you're not sure, next to the chat speech bubble, there are two little speech bubbles together with a Q&A underneath. So that's where we'd like your questions, please. So Katrina's going to keep an eye on those. So I'm really happy to sort of pause if a relevant question comes up. I've looked carefully at all the questions that have been sent in, and I believe they're all incorporated. Well, I really hope they are anyway. So this webinar is all about skin checking, and it's about skin checking in relation to moles or lesions, because sometimes it's a pink lesion, sometimes it's something else. So it's all about how to check your skin and how to self-examine as well. Because we all know that people really, really worry about things on their skin, whether it be, as I say, a lesion, which might be a mole, or a pink patch, or whether it be a skin condition such as a rash or eruption. Now, I haven't been able to include a talk on what rashes and common rashes and eruptions. That might be a theme for a talk in the future. So I am really going to focus on skin checking, lesions, moles, and skin cancer today in terms of signs and symptoms and risks. So I hope that will be interesting for everyone. And, you know, what we're going to talk about is skin moles and lesions throughout the years. So we're going to look through the whole lifespan and risk factors for skin cancer, the different types of skin cancer, including signs and symptoms, particularly early signs and symptoms that you may well pick up yourselves. And of course, then you will take yourself to your healthcare professional for a check. But also how to check and what's normal and when to worry. And interestingly enough, a lot of the questions were about that. When should I worry and what's normal? And then a little bit on how to prevent skin cancer as well. So we'll divide the talk into sections, and the first section will be on skin moles and lesions throughout the ages. So what I'm going to talk about first of all, and I really believe very firmly in this, that it's really good to let people know what's normal. So as I say, I can't tell you who I work for because it would be advertising, but I do work for a private company that does skin checks, and we have a network of clinics through the country, and I work in a clinic in Maidenhead and Oxford. And when people come to me, they're very, very anxious, and they're often focused on one lesion. But I always tell them it's so important for me to check your whole skin. So I spend a good 15 minutes, sometimes more if there are more moles, looking at everything on someone's skin. And as I talk to them, I actually tell them far more about what's normal. And then if we pick out something of concern, we take images, which go to the consultant we work with, who's a medical consultant, and then a report is produced with any sort of onwards direction if there is what we call a lesion of concern. So what talking about normal, I think, is as important as talking about skin cancer. And of course, even though we think of moles, there are other lesions that unfortunately come to us, particularly in the Middle Ages and perhaps older years as well. So let's talk about moles, because everybody has moles, and moles can appear even at birth. 1% of moles are called congenital, but most babies are born without moles. If you want the medical terminology, a mole is called a nevus or a nevi. And it literally is a proliferation, which means a collection through the skin of melanin. And melanin gives our skin color. So this is why moles are brown or black. Or they can be acquired later. And when they're acquired later, they tend to start appearing in childhood. And they then tend to be persistence moles. More moles that gather as people get older also can relate to sun, but then we also get freckles from sun exposure and lentigos, which I'll also explain. Now, even if you have darker skin, and it's really important to talk about people with all skin types, almost everybody has one nevus, but people with darker skin types tend to have less moles than people with fairer skin, and that maybe explains how moles often acquired through sunlight and photo damage. And the number of moles can depend on genetic factors as well as sun exposure and the immunity. Interesting enough, sometimes people have a mole, exactly the same shape or colour mole in a part of their body as one of their parents. So there does seem to be a genetic link. But a caution here, new moles are much less likely over 40 years. So I always say, if in doubt, check it out. So when we start growing moles, we tend to start growing moles in primary school and into teenage years. And you'll find if you have teenage children, or if you remember back to being teenagers, you might remember moles growing. But don't worry, that's quite normal. Under 18, skin cancer is incredibly rare. I often say to people, melanomas affect people between 18 and 108, because that generally spans the adult lifespan. So don't worry about moles growing in young people and teenagers. Don't worry about moles growing in the 20s or even into the 30s. And don't worry about moles growing in pregnancy. Although if anything grows and it's unusual in size, shape and colour, again, we need to check it out. And I will come to that later and give you more guidance. So this is somebody with quite a few moles, and you look at this, and it's probably someone who's middle-aged, and we look at the back and we're checking around. So I generally check in going, yep, normal mole, normal mole. And I use something called a dermatoscope. So I'm actually looking at what we call the structure of the mole. But when we first look at someone, we also sort of maybe pick out moles that stand out, and you'll immediately notice that two of these moles just look a bit darker. This one's got a bit of pigment around it. Now, if the person says, you know, I feel that mole is new or has changed, you get more alerted, because it's not just about what you see, it's about the history. But suffice to say, this is a back of totally normal moles. And as I say, people even worry about colour. Now, I sometimes say, which is a little bit cheeky, that moles actually can be 50 shades of brown. So, you know, the fairer your skin is, the more red or light brown your moles is. The darker your skin is, you may have more darker moles. But as I say, they are normal. I also like people to kind of love their moles, because they are part of you. They're almost like fingerprints. They make us all uniquely individual. So I was just thinking of all the people I see and all the people I try and reassure. And I was thinking about the worries people have about moles. And interesting enough, I did this before I looked at your questions. And actually, a lot of your questions related to the worries I hear. And some of the worries, you know, we'll talk about may have some standing if there's been other changes. So, you know, my mole is large, you know, this mole is bigger. I mean, if it's always been a large mole and it hasn't changed, that's probably fine. This mole is darker. People worry about moles becoming darker. And again, that's important. It's one of the changes we look at. This is a raised mole, and it's actually just started to bleed. People worry about moles that are raised, and one of the other questions is, my mole is raised, it's not flat, should I worry? Now, these tend to be deeper normal moles, flat moles that tend to be called junctional, because they're in between the dermis and the epidermis, which is the two top layers of skin. And dermal nevi form from the dermis. So basically, when they grow up, they've got more growing. So they grow into a kind of bobble on the skin, and sometimes you can move them about. But they have little tiny weeny vessels in them, which are quite normal vessels. They're called comma vessels. So if they knock, they sometimes can darken up because they just start to bleed a bit, and sometimes they can bleed, and sometimes they can itch as well because they rub on clothing. So certainly all these are important signs, but actually that is normal for that normal mole. The other thing I hear a lot is, my healthcare professional said, keep an eye on this mole. Now, this sort of, I feel, is not very helpful advice. It tends to move people to more anxiety, because keep an eye, what does that mean? What are you keeping an eye on? And often healthcare professionals pick a perfectly normal mole. So in my clinic, I often say, well, actually, my mantra is, you need to keep an eye on all moles. You need to keep a lookout for new moles. It's not just one mole you're keeping an eye on. So new moles are important, as I say, but sometimes they're normal. Moles getting lighter, people worry about, and very interesting when you get into your 50s, as I admit I am, you start to lose moles and they do get lighter and paler. I mean, I used to have a lovely Cindy Crawford on my cheek and it's disappeared now. And people worry about losing moles, but that's normal because moles have a life cycle and that's called homogenization. People worry about crusty moles, and crusty moles often aren't moles, and I'm going to tell you what they are in a minute. But then if a mole is growing and crusting and it truly is a mole, again, that would be what we call a red flag, and you need to check that out. So that sort of covers the worries people talk to me about. And that's why I really love what I do, because being able to check people and reassure them is good. But I'm just going to talk about 3 other common lesions, which people really also panic about, which are quite normal. The first one is something called a dermatofibroma. Now, you might not have even heard of this and think, well, what is that? This occurs often in teenagers and adults. Interesting enough, it's nothing to worry about at all, and it's actually a scarring reaction to minor trauma and often an insect bite. So, because we've had such a long, hot summer, I have a feeling, and people have been traveling abroad more, I think we're going to see a lot more dermatofibromas in my clinics over the next 6 months. They can sometimes take about 6 months to develop, but of course they develop like a new lesion. They can feel a bit like a dimple under the skin, and they can be red and raised, and they can sometimes have all the worrying signs and even develop a ring of pigment. So again, this is showing what dermatofibromas look like. And you could think, golly, that is quite worrying because they look like an unusual growth on the skin. So again, to be absolutely certain, you have to get it checked out. And of course, on darker skin, they tend to be darker. On fairer skin, they tend to be more pink, but they really are nothing to worry about. So angiomas, we're coming into our 40s now. And certainly you can develop angiomas, which are vascular lesions, any age, and indeed not to be mixed up with an hemangioma or maybe a strawberry mark that babies can develop at birth, which actually is a vascular abnormality that I generally say with strawberry marks. Babies can be born with them, they go to nursery school with them, but they don't go to primary school with them. So this is similar in a way because it's a little burst of blood vessel from the skin. Now, the thing is they do increase in number from 40. And I put in a bit of dermoscopy there, which is quite interesting because when I'm looking at red lesions, I'm looking for lakes. I'm looking for a sort of divide of stroma between them. It's probably a bit medical, but I'm not looking for vessels. If I see vessels going over the top, I'm immediately concerned. So again, you'll recognize these lovely angiomas. And as I say, you often see them on your trunk and back, and they do increase as you get older. They also can increase in size and get a bit juicy. And again, people worry about the growth, but you know, they are fine. We do have to have a little bit of caution though with pink lesions, because pink lesions can also relate to some skin cancers as well, but more of that later. So when we get to 50, we do start growing some really quite horrible things on our skin. They are called seborrheic keratoses. They have other names. They're sometimes called seborrheic warts. Now, this is a very, very misleading name, and sometimes people start to treat them as warts. They're absolutely not warts. All they are is lazy bits of skin. As we get older, our skin overgrows, and our skin is always shedding. And as we get older, we grow a few more skin cells. They start to stick together and then they become brown and crusty. So the unfortunate fact is that, you know, a lot of people over 50 start to develop 1 or 2, and we say 90% of people 60 plus have 1 or more. And people don't like them because they can be quite unsightly. Sometimes some people grow more than others, particularly if they have had a lot of sun. They can be flat, raised, smooth coloured, warty or waxy, but they are degenerative and part of skin aging really, and due to photo damage. So it's another very good reason to keep your skin well moisturised so clumps of dry skin don't build up, and to use some protection. They like a friction, so you often see them in places where there are flexures, which are folds of skin. So I often see them under a bra line in ladies or maybe under armpits, but they never turn into skin cancer. Now I've told you about them, you may recognize them. So this is an older person's back with quite a lot of fairly unsightly seborrheic keratoses that are proud and crusty from the skin. Okay, so that's all about normal, and hopefully that's reassured you in some way about normal things. So we'll now talk a little bit about risk factors for skin cancer itself. So the first thing is, who is most at risk of skin cancer? So really, the fairer the skin you have and the more susceptible you are to burning, especially in strong sun, and I'll explain what the Fitzpatrick score is, 1 to 2 in a minute, the more risk you have. Because basically, most skin cancer comes from what we call photo damage, or damage from the sun's powerful rays. There are 2 types of skin cancer. I'll go into that's melanoma and non-melanoma. Now, melanoma is a more complicated beast, purely because it is a complex cancer and there may be other factors at play. And melanoma also is a cancer that can appear in non-sun exposed areas. But the non-melanoma, which is very common, and I'll give you the names, the basal cell and squamous cell, and also pre-cancer, which we call solar keratosis or actinic keratosis, is totally about sun exposure and damage from your UVA and UVB rays. But saying that, melanoma is often triggered by intense burning. So this is why we do have to be very careful about our accumulative effect of sun, and also we need to prevent against burning and extra exposure to UV rays. So we need to avoid sunburn, and you're more risk if you have a history of sunburn, people who are sun worshippers, people who have used in the past, or hopefully are not, but still using sunbeds. You are really, really a lot more risk. I cannot tell you, when I see someone who's used a sunbed, I see photo damaged skin way beyond their years. There is no health benefit for sunbeds. I'll leave it like that. You don't get vitamin D from them. They don't prevent disease. And they actually, as they are in Australia and indeed Brazil, they should be banned. And it is an unregulated industry. So obviously, if you have lots of moles and freckles, more moles and freckles, more susceptibility to them changing. But remember, melanoma can also appear without a mole or freckle. Obviously, if you have very red or very fair skin or light coloured eyes, you've just got that great susceptibility. Personal and family history is interesting because people worry about that, and they often come in and say, well, my father had a BCC removed the other week, so I feel at risk, I've had a skin check. I say, well, don't worry, because the non-melanoma really doesn't, apart from perhaps a highly invasive squamous cell, which is very, very rare, it doesn't have a genetic susceptibility, but a melanoma does. So if you have melanoma in your family, again, you're a bit more at risk as well. So this just describes the Fitzpatrick skin types, beautifully demonstrated by my Olympic athlete friends here. So sometimes you see people telling you, oh, you've got type 1 skin, you need to be careful, or you've got type 5 skin, you won't get skin cancer. So that's not true, because people with darker skin certainly can get skin cancer. And I have seen skin cancer in people with darker skin. But people with type 1 skin and type 2 are more susceptible. This is an old-fashioned score, so it's not actually based on ethnicity, but it's based on the ability of the skin to burn or tan. So the typing goes, type 1 always burns, never tans. Type 2 generally burns, sometimes tans. Type 6 never burns, always tans, etc. So you might see this in referral letters if you're referred with a skin cancer, this lady or this gentleman has skin type, and it's just to explain to you what it means really. So obviously, this is a lady with photo damage. So this lady has exposed her face or to the sun without sun protection, and you can immediately see pigmentary changes. And on her nose, you can see a solar lentigo. And people ask the difference between freckles and photo damage. So freckles you're generally born with, particularly have very fair skin, and they will come out in the sun. But lentigos are brown marks that you develop on your skin due to exposure to the sun. So this is the classic photo damage. So therefore, skin protection, not only does it prevent against skin cancer, but it keeps you looking younger. So let's go through also some of the sun damage spectrum. So this is actinic keratosis, known as solar keratosis, or AK. This is defined as pre-malignant. So this is not a skin cancer per se, but the thing is a small number can progress to a skin cancer as squamous cell carcinoma. Up to 80% of squamous cell carcinomas actually do develop from an AK. So there are a variety of treatments. In fact, there's quite a number that your GP can prescribe, because I feel that if there's a number like on this scalp, they perhaps should be treated, because you never know which ones may progress, but sometimes that is discretionary. And the basic treatment actually is to use emollients at night and sunscreen in the day. But if they become more apparent, there are some treatments. And as I say, these can be prescribed by your GP and diagnosed. So they're incredibly common over 50 years, and they're always seen on sun-damaged skin. And again, this is a gentleman with thinning hair. So gentlemen or other people with thinning hair are more susceptible on the scalp. You can find them on your ears, your nose, anything that's sun exposed. There can be a single lesion, and this is a single lesion there, but also this is a whole area of AK. So we call this field damage. So you can have quite an area. They feel sort of quite like sandpaper when they're forming. So if you run your hand over your face or your scalp and you feel a sandpaper type feel, that might be one way to sort of work out if that's an actinic keratosis rather than dry skin, and then you'll see the lesions form. So again, if in doubt, check it out, go and see your GP. I think the spectrum's really interesting because we've looked at photo damage, and we've seen a gentleman in the previous slide with AK or actinic keratosis. And basically this is a spectrum. So the squamous cell carcinoma really is stimulated by an accumulative effect of UVA light over the years. And that's how it can lead to a squamous cell carcinoma. So when we look at skin cancer statistics, I'm just going to pause in case there are any questions, because we're 1:30 now. No, okay, I'll carry on. So a lot of people say, well, how common is skin cancer? What are the statistics? So we're very lucky because skin cancer research produces statistics periodically, and the latest figures were 2016 to 2019. So as I say, you have two types of skin cancer. So we're now talking about melanoma, and we're talking about non-melanoma, which is basal cell and squamous cell. Now I'm about to explain what those two cancers are and give you some examples. So if you look at the pie chart, melanoma is probably about a tenth of the non-melanomas. But the really worrying fact is that melanoma is still climbing steadily in the UK, to the extent that it is now the 5th biggest cancer in the UK, with 46 cases a day. Non-melanoma, there are a lot more. And then if you divide the pie, you can see that 1/3 are the basal cell. Now, the good news is the basal cell is the good cancer in a way, because even though it's destructive and you often have to have surgery and often left with a scar, unlike the melanoma, it doesn't spread. It tends to sort of sit in the superficial layers of the skin, whereas the squamous cell carcinoma does have a potential to spread. So therefore, there are still deaths from non-melanoma carcinoma, which will generally be squamous cell, which is about over 1,000, but the figures are frightening enough, really, that that's what there is around in the UK. And of course, if you compare it with Australia, Australia's statistics were sky high, particularly by the time the 80s came. There were people having melanomas within the Australian community, and there were a lot of deaths. So the public health campaign, which is called Slip, Slap, Slop Slide, which everybody kind of knows and it rolls off the tongue, was developed as a very aggressive public health campaign with very frightening adverts on the television. And now, you know, in every public place, there's a vats of sunscreen for people to help themselves to. Children go to school with hats, and everybody is so aware now in Australia, and it took 20 years to actually reverse the figures and see a decrease in melanoma. But in the UK, this is climbing because we don't have the same public health messages. They are there, but they're perhaps not publicised. So we now look at the different types of skin cancer and the signs and symptoms, which might hopefully help you understand what you're looking for. And we also will look at skin checking as well. So this is a nice diagram with the two types of skin cancer. I've mentioned the two types of non-melanoma, which are the main types. There are some rarer forms. I thought I ought to put it in just in case anybody's heard of some of the very rare types, but they really are very rare. The thing is, they're all about cellular change and they're all cancer, but it's all about the growth and how that cancer behaves in the skin. So for instance, when you have a basal cell carcinoma, interestingly enough, they generally develop at the deepest level compared to the other two. But they grow up and they destruct outwards as they go. And the good thing is, as you can see, they never go into the bloodstream or the lymphatic system because they're contained within the epidermis, which is a cellular system with no blood vessels or lymph nodes. So they do destruct, and they can be pretty destructive. And when you have them cut out, it's a little bit like an iceberg because there's generally a third on the skin and 2/3 under the skin. Whereas the squamous cell carcinoma has a slower growth rate. So the cells will start to divide and it will grow slowly, more horizontally through the skin, with the exception of one aggressive form of squamous cell carcinoma, which is 5% of them, which is called a highly invasive one, which will also grow vertically straight down into the skin and here into the bloodstream. Whereas the melanoma is very aggressive. And the reason is that it has a vertical growth. So as quickly as it's growing up to change a mole, and remember with melanoma, 50% change a mole on the skin and 50% develop a new mole, which of course isn't a mole, it's a melanoma. But at the same time, they grow down quite rapidly. So that they break off, they grow, and they can hit the bloodstream and the lymph nodes pretty quickly. And you see how close that lymph node is. And this is why, you know, the progress in melanoma care has been phenomenal over the last, well, within this century. And now most people who don't have a melanoma that's defined in situ, and in situ means within this top layer of skin, the epidermis, they will go and have a lymph node biopsy to double check or hopefully not for spread. So I think if you look at how they grow and how things change, a melanoma generally will grow within weeks, whereas a squamous cell will grow within months. And a basal cell, interesting enough, can grow over years. Some people say it's the only cancer related to a longer life, because obviously the more sun exposure you get accumulating through life, the more chance you have of developing one. So we'll now look at some of the basal cells in more perspective. Oh, there is a question, Katrina. Did you want me to? Oh, can't hear you.
Sorry, yes, it did come in just as you were in the middle of talking a bit earlier. So I don't know if you want to read through it
to people. Yes, I will.
I didn't know if it was really relevant for now, which is why I
okay. I have atopic dermatitis, being referred to phototherapy for treatment. I have fair skin and I'm trying to evaluate the risk of phototherapy sessions in my case. Do you have any advice for me, please? Should I avoid phototherapy? It's a good question. Thank you for asking it. I think it's I'm just trying to answer it succinctly. Phototherapy, and of course you've asked this because I talked about sunbeds. So phototherapy is not sunbeds. It's targeted UV light and it's a treatment. And what you will be offered is something called narrowband UVB. In fact, most tannings are tanning a UVA or UVB combined. So it's a completely different type of light. It is evaluated as a treatment that is it is a treatment that is safe, that obviously you are getting some light, so it does slightly increase your risk. But actually what we do is, if people have phototherapy in hospital, they're actually only allowed a maximum amount, and we measure it in joules. So that's why phototherapy courses are offered in sort of short, sharp courses. So again, you know, if you've been offered it for atopic dermatitis, you're probably on what we call an advanced therapy route for eczema. So, you know, often phototherapy is tried first, and if that doesn't work, then you may move to other treatments such as immunosuppressants and biologics. So I think there's a great deal of research and a great deal of safety around administering phototherapy of eczema, and it wouldn't be offered if they felt you were at any sort of greater perceived risk. I think that's probably the best way of saying it. But I think if in doubt, again, just have a chat to your dermatologist about it.
Julie, can I ask, is the phototherapy, is that the same UVA, UVB, whatever, that you have for psoriasis?
Yes, exactly the
because
same.
We were working with a nurse down in Bath, because, you know, as I think you just said, there's only a certain number of sessions that one is allowed to have. And the record, or how the hospital keeps those sessions, quite often is by paper. And also, if you move out of area, then they don't translate how many sessions you've had. And the nurse that we were talking with was trying to build a record, for a national record, because some people get very close to that number of sessions. So what I was going to suggest is that I think it's really good for people to try to be aware of that themselves, rather than relying on the NHS, is also to try to be careful about record keeping themselves. I don't want to scare anyone, but I think, I don't know if it's changed recently at all.
I would say that now, because records are all electronic, I think they would be well kept. I think it's a really good idea to have a national registry for people moving.
Yeah.
I remember when I was a ward sister and I used to run phototherapy sessions, we literally wrote down the joules of the patient in a book. And so I agree.
Yeah. This was only 3 years ago.
Right. Yes.
So
I mean, it should be electronic. But I think I agree, and maybe that's a good tip for the person who asked the question, that when you start phototherapy, keep your own records. Maybe. Yeah, I think it's a really good tip, because it can, you know, there is a slight tipping balance with phototherapy.
Yes, I think some people are actually given a little book themselves to keep, but it's just, be aware, do not assume the NHS have a record, or have a record that will necessarily transfer into another region, because we do know they work quite often in silos with the digital technology.
Yes, I mean, I do also know that there have been quite a few litigation cases about phototherapy where people have burnt, and I don't want to scare anyone. So I would say phototherapy records should be pretty robust. But as you say, we hope. Can't speak for everyone. Yeah, okay, that's a really good point. But I think, you know, I always say to people, trust your dermatologist, trust your dermatology department. If they're offering you a treatment, they will talk to you about risk benefit, and if they feel phototherapy is going to be beneficial to you, that's why they're offering it. Do you know what I mean? Yeah. So it is about that sort of trust and asking lots of questions. And the nice thing with phototherapy is people quite enjoy it, because even though it's quite time consuming, you always get to see a dermatology nurse. Generally, it might be someone else who's giving the therapy. So at the same time, you can always chat about your eczema and how you're feeling. And people often find it very supportive in that way, or albeit time consuming sometimes, but I'm sure it's worth it. So moving on to basal cell, just to tell you what it looks like. So with basal cell and squamous cell, remember, they're not moles. When you talk about moles becoming cancerous, that's melanoma. So basal cell and squamous cell generally are what we call pink patches, but just from a lay terminology. So there are 5 types of basal cell, but I'm only going to trouble you with the 2 most common, and this is the ones you need to look for. So they appear on sun-exposed skin, and they can be superficial, which is a pink patch that often has a little bit of a crusty area. So the message is that if you grow something pink on your skin and it's a bit crusty, it may bleed a bit and it's not healing, don't accept something that's not healing as just being me or just being me getting older. Always get it checked out. As I say, they do take quite a while to grow. They can also grow into sort of pearly nodules as well, with a rolled edge. And this is rather lovely, this one, because can you see the blood vessels? We call this arborizing telangiectasia. So basically little vessels like the branch of a tree. And that's called a nodular BCC. So they're the most two common types. So this is a magnified view, but sometimes if you see somebody, particularly maybe an older relatives, and you see they've got a shiny nodule and you can see little vessels joining in, you may even detect a basal cell carcinoma yourself. If they're on the face, they are generally referred within the 2-week wait system. But if they're on the body, as I say, because the potential to spread is just so rare, it's the tiniest percent. And they really don't, to be honest. You might be on a routine wait. So don't worry if you are put on a routine wait for basal cell carcinoma. Of course, the C word and description doesn't help. And then sometimes people refer to them as rodent ulcers. I always think this bit of history is quite interesting. I think I've just about got time. So BCCs were basically discovered in the Victorian days when the people who were working on the new roads and asphalting and tarring roads, because that's what happened, after the Industrial Revolution, were working with these chemicals that actually made them more photosensitive to the sun. So they started to develop basal cell carcinomas, which, like this one, almost looks like a chunk's been bitten out the skin. And because and remember, the gentry in Victorian days, they didn't want to have any sun on their skin at all, and they often really favoured the very pale white powdered look, and that didn't change until Coco Chanel in the 1920s made tanning fashionable. But anyway, these poor workers, they would go home, and if you've ever read books of that era or even later, you will know that a lot of homes were infested by rats. And so people used to think that these areas often on their faces were rat bites, and the rat had bitten them overnight. So that's why they're called rodent ulcer. But I promise they have nothing to do with rats nowadays. So the squamous cell carcinoma is slightly different. It is from the keratinocytes in the epidermis. So these are the skin cells, the cells that cause scale. And they do tend to be quite nodular, but they tend to erupt a bit more. So I always say they're a bit more volcanic. They sort of erupt with a crust and with a firm, fleshy base. So firm, fleshy is quite an important description, and they can be quite destructive as well. So BCCs are more like the volcano crater, and SCCs are more like the volcano eruption. So melanoma, of course, is so worrying, and we need to prevent melanoma. We need to prevent people dying. And sadly, disproportionately, numbers of people with melanoma are often in their 30s to 50s. Although remember, as I said, melanoma can occur between 18 and 108. So this is when a mole, and you can see it's a bit of a close-up of a similar back, but you can see lots of normal wells around it. And suddenly this one, my goodness, does it stand out at you? Can you see the differences? It's not a normal even mole, even to the eye. You're seeing it's growing, because basically all the changes of melanoma are about growth of the melanin. So it's asymmetrical. It has an uneven border. Look at the color, different colors, 2 or more, 3 or more colors really is a real alert sign. And it's grown in diameter. So we haven't got a tape measure on this slide, but if you had a tape measure, it probably would be bigger than 6 millimeters. And that goes back to my earlier point. Big moles that have always been big and stable are not necessarily bad moles, but a big mole that's growing and changing and looking very different over weeks, months is a bad mole. And that's what we're really looking for. We also look for evolution, and evolution means a new mole on the skin or a mole that's growing on the skin, and certainly a flat mole that grows up. You need to be aware of that as well. So in terms of how to check your skin and what's normal, I'll go through the ABCDE analogy. So this is a bit blurred, I'm sorry about that, but it's really just a schematic thing. And it's basically saying that as we are taught with self-checking of other parts of our body, women should check their breasts every month for lumps and men their testes, for instance, we should try and self-check our skin. Sometimes using a handheld mirror, holding it in front of a long mirror is quite helpful. We should check it every month, because I always say when I do my skin checks are almost as good as the day you do it on. And because melanomas can grow within weeks, we probably should think, put a reminder every month. You need to be systematic, so you need to start at the top and work down and work up. Obviously, get your partner to help you with your back. You can take photographs of your back with a smartphone, and you can almost use that to compare as a self mole map, but only really if you have loads of moles. Often the partner's the best person to maybe notice and look out for a new mole or a new pink lesion that's appeared. And we also need to look for ugly ducklings on our body. I'm going to explain what an ugly duckling is at the moment. But don't forget your nails. Look for different coloured bands. If you have a mole in your nail, it's often a single band. But if you have bands of colour, that can be a worry. Look at your soles and palms for any dark marks as well. And also feel through your scalp and see if you can feel anything part your hair, and just check what that is as well. So, checking your whole body is a little time consuming, but it is very good to do. Of course, one of the questions was asked about apps. So I sort of slipped in a thing about apps, because a lot of people think, well, if I just put an app on my skin, then I get an instant result. Now they're all private, so you'd have to pay, and you pay per mole. There was a Cochrane review done in 2018. So this kind of is the evidence from looking at studies, although to be honest, there was a small number of studies. They did say that when they explored the studies on a smartphone, there was a chance of missing melanomas with a false negative, because it's only one picture and it's as good as the picture you take. But saying that, smartphones have improved in 4 years, and store and forward images have potential. But I think the thing is, over the last 4 years, what we call AI, artificial intelligence, because that's how they work, these apps. You take a picture of your mole and they're trying to compare it and features. Generally, if there's any hint of suspicion, they'll say, some apps say this could be a melanoma, go and get it checked out. And then if it's absolutely fine, or you don't get the forward referral you want, I think sometimes they can cause a bit more anxiety. But I do think we have to watch this space, because I think they are improving and there are lots of apps out there. But remember, this is generally a 1 mole check and you have to pay per mole. Whereas a skin checking service is useful, because you will have a full skin check, and there are several companies who provide this. Sadly, there is no NHS skin screening service. And when you think of the other big cancers, breast, prostate, bowel, cervix, they all have NHS excellent skin screening services. And of course, if you go to your GP or healthcare professional, they will always check a mole. They will often take a picture. They will often even send it to dermatology for advice and guidance. And if they're really worried, and you, as well as the picture, you've given them a history of change, they will refer you on the very excellent NHS pathway, which is called the 2-week wait. So anybody with a suspicious lesion within the NHS will be referred and seen by a dermatologist within 2 weeks. And that has kept very robust even throughout COVID.
Julie, do you know roughly how much one of those skin checking service would be?
It depends. They're generally, I sometimes say they're generally around about 150 to 200 pounds, depending on the company. I think just be slightly careful, and I'm not mentioning any names at all, not even who I work for, but be a bit careful of when you go to a company and they say, right, well, there's a base price and then it's a price per mole, and you choose the moles you want imaged. Our company don't do that. We pay a price and the nurse decides with the client which moles are images, and there isn't a set number. Saying that, my average is probably 3 to 5, because as I say, most of what I'm seeing is normal. But if you just are very sure it's just one mole, there's nothing wrong with those companies. They just have a different pricing structure, really. And I'm sure they all give excellent services. But it is a 30-minute appointment, and you do get a full skin check, i.e. take all your clothes off down to underwear. And then we use something called a dermatoscope. And I can't look at a mole without a dermatoscope because it picks out all the features and then really tells me what's normal and not. And it's quite precise training.
And I can understand why it's not on the NHS, because as you said, you should check it every month, and we can't go and have to check every month. But it's probably maybe a good idea for people, if you're not sure, to go and to have that one off, so that you know what you're looking for, and people say, yes, that's fine, or no, that may not be fine. So I know what you're saying earlier at the very beginning by saying, you know, just keep an eye on that mole, but it's still that sort of getting to understand the moles on your body, which are fine and normal, is probably a very good starting point, isn't it?
It is, and I have to say the self-checkings every month, but a skin check probably is similar to other screening services, probably every 3 years.
Oh, really?
Or if something changes, then come at that point. So you wouldn't come every month. But don't worry. And the photograph is good. So this is an example of a normal mole. So this is a normal big mole. So again, this is someone who was told, keep an eye on it, that's a big mole, but actually that's a really normal dermoscopy. So that's a normal mole, but that's the sort of images we would take side by side. Now, the good thing is if you do go privately, you normally get a PDF report. In fact, make sure if you go privately, your provider provides you with a personal PDF report of your moles with photographs. And of course, you can forward that to the NHS, which is wonderful, because then you help your GP, you save some NHS time, and your GP is reassured as well. So I believe it, you know, I believe some of these private services be very good, because we work hand in hand in a way. So that's how it works, really. So obviously, when you're thinking about if you're worried about a mole or a skin lesion, you need to sort of also try and learn what we call the ABCDE analogy. So you think to yourself, why are you worried? Have you just suddenly thought, I've always been worried about that mole, or has it changed? So, you know, is it new? How long have you had it for? Do you think it's grown? Is it recent or gradual? Has it changed in size and shape? Has it changed in color, got darker? Is it pink, or is it a mole? Or has it been inflamed, itchy and bled? So these are really good questions to ask yourself or check with your partner, obviously. So we use the ABCDE role, and we also sort of add in firm and growing as well. So basically, if a mole is changing, and if a mole is becoming a melanoma, or if a new mole on the skin appears and then starts to rapidly change, what you're looking for is growth. So for instance, these are pretty extreme examples, but this one is completely asymmetrical, and you can see a raised black mole, which generally, you know, is starting to grow pigment down the diameter. So that's growth. The same with border. I mean, this is a very red mole as well. I mean, all of these moles you would be frightened about. They all look terrible. And also they probably all have been growing for quite a few weeks, months. Of course, a mole that was light is going darker. That's important. But remember, the raised moles can darken up because of the normal bleeding. And also a mole that starts growing to more than 6 millimeters. So that's the D for diameter. Evolution is also about new moles, and a new mole appearing on the skin and then gradually getting bigger. And then again, very much with those pink lesions, if they're firm to the touch, like nodular, and you can hold them, and also if they're growing, we add that in as well. A very slight caution, I know I don't want to scare you, but there are a very rare number of melanomas that don't have any colour in them, and they could be pink melanomas, but they're very, very rare. So what I'm saying is that anything pink, firm and growing on the skin, you know, and I think the mantra is always, if in doubt, check it out. Now, I'm close to time, so I just want to whiz on very quickly, but basically the ugly duckling sign is brilliant. So it's the one that stands out and looks different, as in this sweet one on his rubber ring. And that's really, really important, because you can look at somebody's back like this, and we saw this back earlier, and I cut off the top bit with lots of these crusty seborrheic keratoses, which all look similar, and other lesions as well. But do you see, this is a flat black mole that's changing and expanding, and it stands out as an ugly duckling, because you don't get lots of melanomas in a crop, you just get one. generally. There's always exceptions to the rule, of course, but you generally just get one. So you can see that all these look the same, but that's the one that stands out, and that's what we call the ugly duckling sign. Very quickly on prevention, 2 slides. We've already mentioned slip, slap, slop, seek, slide, which is slip on clothes, slop on sun protection factor. BAD say 30 for adults, 50 for children, and they do advise using it year round with sun exposed skin. Slap on your hat, seek the shade, and slide on the glasses and prevent burning. This was quite an interesting last slide of some facts and figures. It was actually one I could download with copyright because it said, please share on social media and other public health sites. So it's just quite, it is actually based on occupational cancer. And that sort of is quite interesting because one risk factor, which I'm sure I mentioned earlier, was that people who work outside, now you don't see people who work outside necessarily stripped down to shirts because health and safety has also helped with that. But you know, construction workers outside for 7 hours a day, and I certainly have done some work in occupational areas of construction workers to do skin checking. If you get painful sunburn just once every 2 years, that can triple your risk. The other important thing to say is that sorry, children who sunburn, you must not get children sunburnt. That can also increase their risk of melanoma. So there's lots of little facts there, which is quite useful as well. Right, okay, so here we go. Any more questions?
Sorry, I had muted myself then. So yeah, no, there don't appear to be any more, but I think that's probably because you were so thorough, to be honest. It was really, really interesting for sure.
Yes, well, I think the final thing to say is I hope I haven't scared anyone, first of all, but I hope I've also raised awareness of what to look for. And I always leave everybody with the very good mantra that if you're really worried about anything on your skin changing, if in doubt, check it out. So go and see your GP.
I think that's really, really important, isn't it? And also just not to use. We had this with Adil Sherez. Dr. Sherez came in and we were talking about skin cancer before, as you know. And there's, you know, it's just, you know, are they carcinogenic? I think they're termed as carcinogenic devices or whatever. Suntanning places, they're so, you know, they are so bad for you.
Ideally they should be regulated, and that's the problem. And a dermatologist cannot see a health benefit from them. I kind of speaking for the dermatology community, because I do completely understand that people run small businesses and it's their livelihood. So I really don't want to upset anyone, but it's very difficult for anybody working in dermatology to see a benefit.
You could say that about the tobacco industry, couldn't you? So it's really tricky.
It is tricky, yeah, but true. Yeah.
Anyway, so yes, thank you very much, everyone, for attending. And Julie, thank you very much for doing all the talking, but you did a very brilliant job. It's really interesting. And I think it was really helpful having the images for sure to be able to really understand what we should all be looking out for. And I know that I'll certainly be thinking about once a month, I'm going to have to get the mirror out and look and, you know, look to see if anything's changing.
Yes, buy a nice big handheld mirror. I haven't got one to show you as an example, but I have got one.
Right, thank you very much, everybody, for attending, and thank you, Julie, again. Thank you.
Okay, bye-bye.
Bye.